Good morning, everyone, and thank you for joining us this morning for the Nursing Health Services and Policy Research Colloquium series. Today, we're very pleased to welcome Dr. Monica DiNardo as our presenter. Dr. DiNardo is a health science specialist and investigator at the Center for Health Equity Research and Promotion at the VA Pittsburgh Healthcare System. Her research emphasis is on theory-based interventions to reduce psychological and behavioral barriers that impact diabetes self-care. She received funding from VA Health Services Research and Development, American Association of Diabetes Educators, and Nightingale Awards of PA to develop and test a mindfulness intervention called Mindstride, Mindful Stress Reduction in Diabetes Education, for improving diabetes outcomes in veterans and other populations at risk for diabetes-related distress. As a nurse practitioner and certified diabetes care and education specialist, Dr. DiNardo has over 20 years of clinical service in diabetes management and education in both inpatient and outpatient settings. She serves on the research committee for the Association of Diabetes Care and Education Specialists, the Behavioral Research in Diabetes Group Exchange, and is past chair of the VA Nurse Research Field Advisory Committee. She served on the writing group for the American Association of Clinical Endocrinologists and American Diabetes Association Consensus Statement on Inpatient Glycemic Control. Her work has been published in the Diabetes Educator, Endocrine Practice, Quality and Safety in Healthcare, and Current Diabetes Reports. Dr. DiNardo completed her PhD from the University of Pittsburgh School of Nursing, where she holds an adjunct faculty appointment. Welcome, Dr. DiNardo. Thanks for joining us.
Thank you very much, Andrew. Let me share my screen here. Hopefully I will do this seamlessly. Okay. Okay, I think we're on a roll. So thank you very much for your introduction, and I'm really pleased to be here to be able to talk about our Mindstrike Intervention, especially because it all started at the School of Nursing. I would like to acknowledge the funding sources, AADE, and also the VA HS-R&D Nurse Research Initiative Award, which funded the randomized controlled trial. So this journey all started with a hunch and an observation that led to a research question and hypothesis testing. Back in the early 2000s, when I first started working with patients with diabetes almost exclusively, there wasn't a day that went by that I did not become very aware and patients did not tell me about the amount of stress they experienced just managing diabetes and how their stress levels affected their blood sugars. They would say, boy, you know, my blood sugars are terrible. I've been under a lot of stress. At the time, I was getting interested in yoga and I was realizing how much it helped me. And I thought, you know, maybe something like this could help people with diabetes who were struggling with some stress. When I started the PhD program at Pitt School of Nursing back in the early 2000s, I was very fortunate to have a mentor, Dr. Susan Cohen, a wonderful person who was an expert in mindfulness, and she steered me in that direction. And that's how this journey began. The objectives today are, I hope at the end of this study, you'll be able to explain advantages of incorporating integrative therapies like mindfulness into standard care processes, and to describe how an integrated mindfulness program can enhance the organization and delivery of diabetes care and education. We'll start off with a couple definitions here. Diabetes distress is a negative emotional state that's associated with depression, but it's independent of depression. It's also associated with decreased self-care behaviors and impaired blood glucose management. Daily self-management burden, the fear of complications, hypoglycemia, lower extremity amputations, all play into diabetes distress. Diabetes distress is also associated with poor diabetes self-efficacy, poor confidence in managing the disease, stigma of having diabetes, and interpersonal strain with family and healthcare providers around issues surrounding diabetes self-care. Diabetes distress is prevalent. It affects up to 40% of persons with diabetes, both type 1 and type 2. So healthy coping is a term that's been identified by diabetes experts, diabetes education experts, as one of 7 key self-management behaviors. It means it relates to the conscious effort to master, minimize, or tolerate stress, including personal and interpersonal conflict. So the operative words here are conscious effort. You know, this does not happen passively. This takes some intention. And then mindfulness, which is, as defined by Jon Kabat-Zinn, is non-judgmental awareness of the present moment experience. So veterans are likely to be at risk for diabetes distress. And we know this because veterans have a very high prevalence of diabetes from studies done at the VA. 1 in 4 veterans have diabetes, compared to 1 in 10 in the general population. Veterans also carry a very heavy burden of psychological comorbidity. So it follows that they may be at risk for diabetes distress, but there really have been no systematic studies. So there's a need to study diabetes distress in veterans and for practical evidence-based approaches that target diabetes distress in this population. Mindfulness-based interventions have shown benefits in veterans with chronic pain, anxiety, depression, and PTSD, and could be effective for managing diabetes distress, but there's very little research and there's none been done in veterans. There was a meta-analysis in 2019 that identified just 8 RCTs in adults with diabetes that looked at mindfulness-based interventions and diabetes distress. And they found, the meta-analysis showed that MBIs are effective in reducing diabetes distress with varying effect sizes. And 5 factors were identified that significantly influence the effect size: higher baseline diabetes distress, if the program is based on mindfulness-based stress reduction. So mindfulness-based stress reduction was the original program developed by Jon Kabat-Zinn at the University of Massachusetts School of Medicine. And this program, in which he worked with patients with an array of complex chronic disease, consisted of 8 weekly sessions. Each session was in an hour and a half to 2 hours long, and there was a 4-hour silent retreat. So it's a very rigid and very structured curriculum. Another factor was a group format. Group format seemed to be more effective when there were home practice assignments. So home practice was an essential component. And when longer term effects were assessed, because if you looked only at short-term effects, the effects could be missed. The mechanisms, however, remain unclear. Another study, a qualitative study, was done at the VA by Martinez and Kearney and their associates, and they found barriers to veteran enrollment and participation in the 8-session MBSR programs. Misinformation about MBSR, not lack of information, but misinformation. So even though this is a secular program, patients were being told by their referring providers that, it was for people who had mental health issues exclusively, or that because it's based on Buddhist and philosophy and Eastern thought, although it's a secular program, that it might be in conflict with their religious beliefs. The deal breaker really were time constraints and scheduling conflicts for all of the sessions. Some of the veterans had problems with group activities. They didn't want to do exclusively group activities, and they really were opposed to groups in which there were a mixture of males and females. There was problems committing to home practice assignments, and there was difficulty understanding the concepts of MBSR. So when we developed our Mindstrike program, not having any knowledge of either of these studies, we considered several issues. And Mindstrike stands for Mindful Stress Reduction in Diabetes Education. And I'll talk a little bit more about why we decided on that context. Our program was adapted from MBSR, but condensed to one 90-minute session with one 30-minute booster session. Issues we considered were keeping it relevant to diabetes management so that it was focused. Creating a program that could be self-sustainable. So we knew we needed to provide a lot of home practice support. There needed to be probably a group and individual format so that we could really be able to connect with all of our participants. And we needed to bring the program to the patient. So it needed to be accessible, and it needed to have a potential for fiscal sustainability within current care processes. So how would we do that within current care? What was the most likely way? Well, it seemed that including a psychoeducational training within established diabetes education programs seemed to make the most sense, because diabetes education is a critical and a very important component of standard diabetes care. And it's not a one-shot deal, as many people may think. There are four critical times to provide diabetes education. So, of course, at the diagnosis of diabetes, but annually, and this is covered by many insurers, annually for health maintenance and secondary prevention, when new complicating factors influence self-management, such as the initiation of insulin or maybe some decompensation of kidney function, or when transitions in care occur, new providers, or discharge from an inpatient setting. So our Mindstrike intervention is a 90-minute intervention, as I said, and it is made to be tacked on to standard group diabetes education. And it can be included as a final component or integrated throughout. The intervention begins with a group discussion. And this is how we engage the participants, and that they get to be more comfortable with each other. We talk about what it's like to have diabetes, talk about the thoughts, sensations, and emotions that may be tangled up with living with diabetes. There's a didactic presentation of physiologic stress theory and how it relates to diabetes. We talk about habitual triggers. We introduce mindfulness tenets like beginner's mind, creating a safe space, non-judgment, non-attachment, self-compassion. Many of these perspectives many of us have not really been enculturated with or socialized with. We do a formal meditation practice as a group, which included a 15-minute body scan where you focus on the breath and on different body parts, and mindful movement, which is just some gentle chair yoga. Set intention for home practice, how are we going to do it, make the intention to do it. And we provided some support in audio recorded guided meditations and home practice materials that included a diary for some journaling. So the specific aims of the pilot study, because after we developed the program, we wanted to pilot test it, was we wanted to explore feasibility and acceptability. Will the veterans like it? Will they accept it as part of their usual care? Will it fit well within existing care processes? Will other providers like it and accept it? Think it's important? And to explore early effects of mindfulness practice on diabetes, distress, and some other outcomes, including hemoglobin A1C, which is an average, it's a blood test that is an average, the 3-month average of blood sugar levels. So we worked with a biopsychosocial theoretical framework. So in the context of a person's allostatic or total lifetime load of stress and their personal resources from their environment and support systems, we would be looking at our intervention through that lens. And we were hypothesizing that practicing and learning about mindfulness would increase mindfulness from dispositional or trait mindfulness. It would cause an increase, it would grow it. It would increase diabetes self-confidence or self-efficacy. It would decrease diabetes-related distress. And it would, all of this, the composite of all of this would increase diabetes self-management, which would in turn improve glycemic outcomes and blood sugar. We also thought that there might be a component where reducing distress could decrease the physiologic stress response by downregulating and working on the HPA axis, which could in turn also help to decrease or stabilize blood glucose levels, but this was not included in our work. So the methods for our feasibility pilot study was a quasi-experimental one-group pre-test, post-test design. All veterans were enrolled and attended the diabetes education class, which was a comprehensive 3-hour class that had been offered at the VA Pittsburgh for about 15 years with the same diabetes educator and a stable group of dietitians. So it was team taught. They were enrolled in this class. They had type 1 or type 2 diabetes for at least 6 months. They had an A1C greater than 7%, which is the cutoff at which the risk for chronic complications of diabetes increase. And they were on stable diabetes medications for at least a month. Our baseline measures, we tested hemoglobin A1C by finger stick. We looked at home diaries for their engagement in home practice, and we looked at satisfaction questionnaires. We also looked at a battery of self-report questionnaires that were validated for mindfulness, perceived stress, diabetes self-efficacy, and diabetes self-management. We did our assessments at baseline, 4 weeks, and 12 weeks. I want to say just a little bit about the problem areas in diabetes scale, or the PAID scale, because diabetes distress was our primary outcome that we were looking at. This is a validated 20-item measure of diabetes specific emotional distress, including a wide range of feelings: guilt, anger, depressed mood, worry, and fear. Higher scores denote greater emotional distress, and the cutoff for diabetes distress is a score of 33. A score of 40 is consistent with diabetes burnout. So our baseline characteristics showed that there were 28 participants who enrolled in the program, and they were older, middle-aged white men, very representative of the population that we see in at VA Pittsburgh. They were generally overweight. Their A1C was about 8.5%. Most had type 2 diabetes. The duration of diabetes was very variable, but there was an average of 18.2 years. Most, or almost half, had some college education or technical school. Most were married and retired or disabled. So what we found in terms of feasibility is that we were able to enroll 63% of eligible veterans. We thought that was pretty decent. And we retained about 71% of those who enrolled in the study. 11 participants, so a little more than half, completed home practice diaries. So they kept up with the journaling. But we realized that a lot of our participants, a lot of the veterans, weren't very keen on that. Mm-hmm. As far as satisfaction, all of our participants said they found it interesting and easy to understand. 96% learned something new and plan to continue practicing. 92% would recommend mindfulness to a class to other veterans with diabetes. And a little more than 3/4 thought that the home practice CDs with the guided meditations were useful and made home practice easier. So, I mean, that wasn't really optimal. We had an array of wonderful participant comments, and we got a lot of our qualitative data from multiple sources, including a focus group that held at the beginning discussion of the intervention. Participants said things like, this program has given me thought about what is meaningful in life. Stress relief is important and attainable. Everyday thoughts and feelings are important. I mean, very rich. Another one said it provides another tool to keep you on track with diabetes. I think the best comment was the person who said, this should help some people if they are willing to commit to doing this. And that is really the truth for any sort of psychoeducational self-help program. It really is up to the individual. So motivation is key. We did qualitative analysis of veterans' experiences with diabetes from the focus groups, and we identified 5 major themes, and they all related to diabetes distress. The veterans talked a lot about having negative emotions and feeling socially isolated. They had a perceived lack of control. They were able to control many things in their lives, but they just couldn't control diabetes. It was like having a tiger by the tail, one person said. There was a lot of burden associated with the day-to-day, unrelenting self-management. They had unmet social support needs, and there was problems with relational trust with family and with healthcare providers around issues of self-management. And they all really, and many of them expressed a need for more information about stress and diabetes and how stress can affect diabetes and how they can manage that. From baseline to 12 weeks, we had significant gain scores with varying effect sizes. And interestingly, we had a very dramatic decrease in diabetes distress with a large effect size. We also had significant changes in many of the other outcomes that we looked at, including self-efficacy, self-management, A1C, taking medications, healthy eating. But again, there was no control group here. Pre to post changes, again, significant improvement in diabetes self-management, significant improvement over the 12 weeks in self-efficacy with a progressive decrease in diabetes distress and an initial decrease in general stress. So we had our findings of this pilot study published in a peer-reviewed diabetes journal, our qualitative and quantitative results, and we were on a roll. We were off to our randomized controlled trial, and we were lucky to get funding. So some of the procedures of our RCT, our power analysis told us that we needed 104 participants to detect a group difference in diabetes distress based on the effect size. Again, we recruited from the diabetes education class roster. That seemed to work very well. But this time we made a lot of efforts to reach out to VA providers in our different areas, our primary care providers, the women's health clinic, the podiatry clinic, the kidney service, looking for referrals to diabetes education from multiple providers. We also did mass mailing in participants who are identified in the corporate data warehouse of having diabetes and having an A1C over 7% that lived within a certain geographic area. Inclusions again, attendance in the education class, having diabetes, A1C over 7%, but this time they needed to have a positive screen at baseline for diabetes distress. Exclusions were documented cognitive disorders, current meditation practice, so we wanted this to be something new so we could measure change, and patients were excluded if they had attended the group diabetes education class within the prior year. We extended the study to 24 weeks from 12. We provided monetary compensation for each visit completed. I did the intervention for the pilot, and so to eliminate interventionist bias, we had other people do the intervention, and we trained them in MBSR, and also they had training in diabetes education, just kind of like a diabetes education 101 through the Diabetes Institute. We really hope to have nurses and diabetes educators or do the intervention, but we weren't able to do so. So we ended up having allied professionals. There were 2 social workers, and there was a physician's assistant. So it was really a multidisciplinary effort. Each Mindstrike intervention was recorded and assessed for fidelity. New procedures where we added a few assessments. We added the PHQ for depression. We added the abbreviated PCL to look for symptoms of PTSD. We added a second mindfulness questionnaire, the MOS, the Mindful Attention Awareness Scale, because we wanted to be able to get a composite score for mindfulness. And we added a different diabetes self-efficacy instrument, the Stanford instrument. This time we had hemoglobin A1C was done by a lab draw to improve accuracy over finger sticks. And we put a lot of effort into retention and engagement. We created a nifty new spiffed up workbook. And we, very importantly, we partnered with the VA Center, National Center for PTSD, who develop apps on their already developed Mindfulness Coach app. This app was a digital application which is publicly available on iOS and Android, was developed initially for PTSD. We were able to include our file, our Mindstrike information on the app as well. And we worked with the developers to be able to get some app use data from the back end. And we also incorporated between visit phone calls at weeks 2, 8, and 18. So our RCT was conducted at the VA Pittsburgh from 2016, and we had our last assessment visits in April of 2020. So we got in there just right at the beginning of the COVID pandemic, and we were not really very affected by that at all, fortunately. 132 veterans were randomly assigned to one of 2 groups. The group that received Mindstrike, the Mindstrike group that got standard diabetes education and care, it was ongoing from the providers, the group diabetes education class plus the mindfulness intervention, which was integrated into that, or the control group, which had their standard diabetes care and just attended the group education class without the mindfulness training. We did assessments at baseline, 12 weeks and 24 weeks. There was a booster at 1 month, And this was really standard care for the diabetes education class. So we just tacked on our Mindstrike booster with our interventionist at the same time. And these were done individually, not as groups. So there was the group component of the class and then the individual component for the booster. Between the 12-week and 24-week assessments, we did qualitative interviews with a subset of 25 veterans who were in the intervention group, just looking at their experience with the program. So this is a little glimpse at our workbooks. So this was our logo that was developed by the study team. And we did things like, what is stress? What is mindfulness? Mindful breathing, mindful eating. So sort of reviewing many of the things that concepts that we introduced in the initial training. We also did weekly, we had weekly assignments, and it was organized on a weekly basis so that each week they had a little assignment to do. There was an opportunity to do some logging if they preferred a written logbook. We had some inspirational quotes. And the important thing about this, I believe, is that the assignments were very detailed from weeks 0 to 12. But from weeks 12 to 24, they became much less structured, much less described, so that we were trying to guide the participants toward a more independent mindfulness practice. And here is the app. This is the tile from the Mindfulness Coach App. You can track your progress, goals, mindfulness mastery, and their practice logs also on the app for people who are more comfortable with that. This is a very cute little visual. This tree shows up as a little sprout, but as people develop or grow their mindfulness, the tree grows. And then this was our Mindstrike file, the first page of our Mindstrike file that appears on the app. So our results, baseline characteristics, again, predominantly older white males with type 2 diabetes. There were no significant differences between groups on baseline characteristics. A1C, again, the average was around 8.6. The duration of diabetes was about 13 years with wide variation. Most were married, most were retired or disabled, very similar to the pilot. When we looked at baseline scores and compared them on the initial self-report questionnaires, we found no significant differences between the intervention and control group. But looking at the scores, just to give you a little snapshot of who our participants were, specifically, they were a pretty stressed out group. Their diabetes distress level was over the cutoff of 33. They were probably had as much trait or dispositional mindfulness as the general population. They were mild to moderately depressed in general. They had some PTSD features, and they were close to the cutoff. The average was close to the cutoff for a positive screen for PTSD, and they were less. They had less self-confidence. They felt less self-efficacy than the general population toward diabetes. So at baseline, we found some univariate predictors of diabetes distress. And this really was very much aligned with what we suspected with our hypotheses. People who had higher mindfulness and more diabetes self-efficacy had lower diabetes distress. Made sense. And people with higher PTSD scores and higher depression scores also had higher diabetes distress scores. Also made sense. Here's our consort chart of our study. And so there were almost 500 people who completed telephone interviews. Of those, we randomized 132 into the two groups. And we had 10 people who did not complete the intervention group, who had either dropped out or were discharged. There was one discharged because they didn't attend the initial training, and 7 who did not complete the control arm. So pretty consistent. Now, because we did an intent to treat analysis, all 132 were included in the analysis. So our primary outcomes. So when we looked at group by time effects between the intervention and control group for diabetes distress, we found no difference. There was no significant difference. And that is because both improved. And I think that really goes to, makes the point that diabetes education works and that it's important. But look at this. This is the Mindstrike group, and there was the decrease in diabetes distress initially at 12 weeks, but it continued to decrease significantly between weeks 12 and 24, where the control group had that initial improvement or initial decrease in diabetes distress, but that did not decrease further, and in fact, it started to trend upward again at week 24. This is important because we know that even though the diabetes education is very effective, but we also know that the durability of its effects is very variable and usually does not last beyond 1 year. Now, when we stratified our analysis for diabetes distress by A1C, we found that persons who had an A1C less than 8.5 had significant improvement in diabetes distress, a significant intervention effect. Whereas those that had an A1C greater than 8.5 or equal to 8.5 did not. So we learned that this type of intervention, or this intervention, was more effective in people whose A1C was not still high, was still elevated, but it was not terribly elevated. And there could be, several reasons included in this. We didn't look really closely at adherence. There could have been adherence issues. There could have been some issues with the people who had very uncontrolled, very high A1Cs. It could be that their medications had not yet been optimized. Or it could be that there could have been some other social determinants, maybe literacy or some other issues that we did not assess that could have been at play here. So when we look at our secondary outcomes, we really see a very similar picture. There was no intervention effect between the intervention for the intervention by group and time for any of the secondary measures. And that, for the most part, was because they all improved in both groups. Again, diabetes education is important. The only thing, interestingly, that did not improve in either group was mindfulness. So mindfulness did not grow. It did not change. Now when we look at trends over time in our secondary outcomes, with the blue line being the intervention group and the red line being the control group, this is diabetes distress, we see that trend where we have a sustained decrease in diabetes distress over the 24 weeks, where in the control group it leveled off. We see similar patterns for PTSD and depression, and the flip, so an increase in diabetes self-efficacy was noted that sort of continued, perhaps a little bit with a little bit more strength than we saw in the control group. And A1C, we see this very profound decrease over the first 12 weeks, sustained in the intervention group. It begins to drift upward in the control group. We also looked at blood pressure and body weight, and they remained essentially unchanged in both groups. So here's our diabetes self-management scores, and we did find a significant group by time effect only for general dietary behaviors. And so the mindful eating may have helped. We looked at engagement in home practice. Did people who practice more at home have better effects, better results, better outcomes? And we gathered the engagement data through the app, through the journal entries, satisfaction questionnaires, and phone calls. So multiple sources. We found that our participants in the intervention group, of course, practiced either formally or informally for an average of 3 days a week and 20 minutes per occasion. So formally, really, by formally, I mean they practice mindful meditation, where they're actually doing the focused breathing and doing a more formal meditation practice. Those who practice informally said they really made an effort, again, that concerted effort to be more aware of what was going on in the moment. And they may have done things like mindful eating, so that they were more aware of the experience of eating. And so we consider that informal practice. About half of our participants, a little more than half, we considered highly engaged. About a third were less engaged, and less than 20% were not engaged at all or dropped out. We found that the more highly engaged participants tended to do more of the formal mindful meditation than the informal. So when we look at home practice engagement in the higher engagement group and the lower engagement group, and the way that we stratified these or categorized these was that we considered higher engagement if the participant practiced at home at least 2 times a week, and there was no more than a 3-week lapse between sessions. So, I mean, pretty loose requirements. And the lower engaged people practiced less than that. And what we found was over time that there were significant improvements in diabetes distress in both groups. And looking here at the graph, you can see that there were improvements in both groups, but that the magnitude of improvement in the group that had higher engagement was greater. So our strengths and limitations. Of course, there were strengths and there were limitations to the study, like every study. We feel that our strengths were that we included objective measures in addition to self-report measures. A1C, blood pressure, and body weight. We were able to successfully integrate this program into existing care, to an existing program, and into a publicly available VA application. We had acceptable recruitment and retention rates. We had high satisfaction ratings, and patients for the most part, participants for the most part, were pretty engaged. I did the, as I said, I did the intervention for the pilot study, but for the RCT, we had 3 different mindfulness interventionists who, one for the first year, one for the second year, and one for the third year. And so this reduced instructor bias because we really didn't see any changes that were associated with specific instructors. Our limitations were that it was offered at just one site, which limits our generalizability. There were few women participants, even though we tried very hard with our recruitment efforts in the women's clinic at the VA. Even though we had acceptable recruitment and retention rates, 49% were really not highly engaged with the practice. So could we have done more? Possibly by some text alerts or alerts through the app to remind people to practice each day, more frequent phone calls. So we probably could have been a little bit more involved there. And even though we know that diabetes education is part of diabetes care, we really didn't include a third arm that didn't receive any diabetes education to look at just diabetes care without education and care with mindfulness. So in conclusion, an integrated mindfulness intervention may increase the magnitude and duration of effects of standard care and education on diabetes distress, psychological distress, eating behaviors, and glycemic outcomes. And we had we showed significantly greater improvement in diabetes distress in persons who had moderately increased A1C as opposed to higher A1C, which helps with candidate selection for this type of program. More highly engaged persons had stronger reductions in diabetes distress, although both groups had, within the intervention group, showed reductions in diabetes distress. So maybe just having that increased awareness, maybe just planting the seeds was important. And then also people who had access to other publicly available mindfulness resources. And many of our participants did tap into those. And some actually did go on to attend the 8-week MBSR program. And we found that this can be implemented, our program can be implemented in usual care processes with minimal additional resources. Effects appear to be self-sustaining. We were not able at all to determine mechanisms, but we were able to show that a mechanism does not appear to be related to changes in mindfulness, at least as mindfulness is measured by our current subjective measures that we have available. And perhaps a program such as this may help bridge the gap between the clinic and the home for persons with diabetes. So next steps, dissemination of our findings through publications and presentations like these, so thank you. We still need to do our mixed methods analysis. We have some other outcomes that were included that we have not analyzed yet. We looked at sleep, insomnia, and we looked at sleep quality, and we looked at pain interference. So that still needs to be explored, as well as social support. And then future studies could involve a multi-site study. We could see if this can be replicated using telehealth delivery of the intervention. We all know how that important is now, especially the pandemic has shown us that. And maybe focusing on special populations such as women. And this is our Mindstrike team. So we had a wonderful group of experts and researchers, and the people at the VA Division of Endocrinology, Dr. Rao, and the diabetes educators were just wonderfully supportive. So thank you very much for your time and your attention, and I'm happy to take any questions or address any issues you may have.
Thank you so much for that presentation, and really appreciate you making the time to share your research with us. Gosh, what a big topic, and encouraging to see an intervention that seems to be, making some progress in this area of diabetes, and also one that, is up the alley of nurses in terms of education and whatnot. I definitely have some questions, but we have a great turnout today and a number of people on the call, and I see some cameras turning on, so I'm guessing there are going to be some questions from the audience today. So let's start with those. Who would like to go first?
I can. I'm Denise Sharon-Puchownik, and a big fan of Monica's. I've always been a big fan of Monica's. Beautiful job, Monica. That was so well done. And I just wanted to say, this is really important stuff. You have made an impact. And to show that there's sustainable results, that's important, that things are sustained for 24 months. So to stay in there and people have to measure it long term, I think that was a really important finding in your study. And there may not be some statistically significant outcomes, but clinical significance is there. I mean, look at all of the changes in the hypothesis direction that you saw. And so I really like your continuation, what you're thinking in terms of continuing on this goal. Two questions. One is mindfulness. It was state. Did you measure both state and trait? And could that have been a difference in your findings too? And the second question is partners, social support of partners. Did you look at that? Because that may have been a contributing confounder or a contributing moderator in your study as well.
It's true. So very, very interesting. Well, first of all, most of the instruments really do look at dispositional or trait mindfulness, and that really is all that we looked at. There may be some new instruments now that are more robust and can look at changes in the state of mindfulness, but Carol Greco, our expert, seems to really think that there is an absence of really robust measures that can measure changes in mindfulness. So I think that work still needs to be developed. Certainly, in terms of partners, we invited people to bring their partners with them, bring their spouse, bring a friend. Very few did. There were a couple, and there were a couple of people who practiced mindfulness along with their wife, with their spouse. But most people went it alone with this.
I was just wondering if they measured support too, because sometimes you'd see support as being one of you didn't measure perceived support.
So we did.
We did. Okay.
Not analyze that yet. So it's measured. It's not analyzed.
Okay.
But about a little more than half were married or had partners. Now, how effective that partnership was in helping them, we don't know. So that would be interesting to explore.
Thank you.
Thank you.
Interesting work, Monica. I really I'm really fascinated how you actually included more than strategy of within your RCT, you had the app, you had mindfulness, the Mindstrike like embedded within the diabetes education and the home practice. So that was like really interesting, and I mean like it's fascinating how you like were able actually to approach it more, like make it more practical and visible to participant. Yeah, so I can see that. Actually, I have two questions. One of them, like the dosage. Do you think like if we had like higher dose of mindfulness, like if you compare like the Mindstrike with other mindfulness intervention that like followed the MBSR, which is like the 8 weeks or 12 weeks, would that like make really like clinical and statistical difference between like the Mindstrike and diabetes education? So that was the first one, so the dosage. And the second thing was like, it really was interesting that the diabetes distress change was among those who have like good control of diabetes versus those who's poorly controlled. Because like, I would think those who have like poorly controlled diabetes will have like higher level of diabetes distress, and then like mindfulness may be more helpful to them. So that was like really interesting. Yeah, and like if there's an explanation. Okay, thank you.
Thank you. Yes, I think the dose is an issue, and I don't know the answer to that. I think that they may have done better, but were there advantages to making it so accessible and so easy that they, were really able to embrace it, kind of eliminate some of those barriers, and then the people who really were interested could go on to seek out other resources or an 8-week program. So I don't know that you can go, I don't think you can go head to head with an 8-week program, but this was introductory, planted some seeds, and, so it might've been interesting to make that comparison. And it would have been interesting to see in terms of attrition, if people really stuck with it, and, who does. So yeah, dose is a thing. And what is the dose? I mean, even if we would have had another session a little bit farther out, would that have made differences? We don't know. We've tried to keep it very easy. And then in terms of, what was your second question? I'm sorry.
Like it worked better with those with better controlled diabetes.
And I think, well, first of all, the stress levels, not really diabetes distress, but there was no difference between groups. But we measure general distress, like perceived stress. And the people with the highest A1Cs had the least amount of stress. Basically, they don't care, so there's that they don't care aspect to things. But it was surprising to us, and I think it's useful to see, it helps you to target the population that this might be most useful for, to using it within what population. So.
Okay, interesting.
All right, thank you.
Good. Yeah.
Monica, great presentation. I learned so much. Thank you. My question is, two questions. One is, this seems like a very low cost intervention that could have high impact for saving money. And so I'm wondering if you have any plans to look at the cost impact or those projections over time of better controlling diabetes with this intervention. And the second question is, did you get any sense of clinician buy-in when you were doing this, of how valuable they found this, of how worth their time they found this to be with patients? Because sometimes I feel like a therapy or an intervention like this can be challenging to get the majority of clinicians outside of a study to buy into. So I'm just wondering if you can comment on that at all.
Sure. So I think a cost effectiveness study, it would be very important, and I think it would be important to do. And I think particularly when there are more sites involved, I think it would really play, it'd be very important to play well into that. Secondly, the buy-in from the endocrinologist was wonderful. And we continued to get referrals even after we were done enrolling people.
Okay.
We actually got calls from people, so who were also interested. So there was patient interest, there was a good buy-in. Now I can't say that was the case in all of the clinics. I mean, some of the specialty clinics, were more supportive than others. Primary care was very supportive, and they bought into it. So you didn't really see that resistance like you might see with some other programs. And I think because people need, I mean, there's something missing, people really need a lot of support. And I think that the providers were happy to have this potential resource.
Great, thank you.
Mm-hmm. Thank you.
I'm also curious. I think, Tiffany is thinking along some of the same lines as myself. I was thinking about cost effectiveness and also thinking about interventions like these in the context of a broader movement, perhaps, to consider prescribing things that aren't medication. Recently I saw something about prescribing diets, and so I wonder, and then the policy side of me is thinking about insurance and whether you see any future or see any discussion around this or similar interventions in terms of reimbursement. Perhaps it's low cost, but perhaps this will be incentivized through insurance companies. Have you given any thought to that? What kind of evidence do you think they might be looking for? I think the cost piece is important, but maybe that's something to keep in mind too as you're designing that next study. Just wondering your thoughts on that.
So yes, I mean, I think studying costs would be very important. Of course, looking at outcomes, various outcomes. They are, there's a whole health movement at the VA, and little by little, they are really trying to get this up and running. And they are looking at reimbursement and coding, and so all of this is very important. It still leaves the issue, though, and I think the more options there are for being able to get these sort of interventions. So do you send someone off to an intervention somewhere is there a group? Is there a whole health clinic that they have to go to? Or is there an advantage to bringing it to them within the diabetes clinic where they're going anywhere? So I think those are other discussions. But yes, I think more and more, at least in the VA system, I see that there is going to be some coding and some reimbursement for these wellness activities. I mean, you can even look at some of the insurers now, UPMC for Life and so forth. I mean, there is such an emphasis finally on health promotion and wellness. I think it's only a matter of time until this becomes much more part of the mainstay. And at least my hope, and I kind of think things are going that way.
For sure. Yeah, that's awesome. I have maybe a related question, which is, I think you mentioned that the app is publicly available. And so I'm guessing that the individuals in your study, downloaded the app from the publicly available platform. Do you have any information on whether the public outside of your study have found the app? Have you made any efforts to advertise it? Do you know, are people, using search terms? Is there already an interest out there for something like this, that they're stumbling upon your app, downloading it and trying it? What kind of information do you have outside of the study itself?
Andrew, I have no information on that, and now I'm going to get it. So that I have to contact the people in Palo Alto. That's a great idea. I didn't even think of that.
Yeah, it would be so interesting to know, there's so many apps out there that I think to find it and download it might be some measure of just general interest in this app. And there might even be, I don't know what kind of back-end information these people have, but I'd be super curious to know.
Well, yeah, I'll tell you, the information that we got from the back end was not easily decipherable. I mean, we thought we would have this whole slew of very easy to use information, and it wasn't. I mean, really trying to get it in a manageable form was kind of tough. And the thing about our app too is it's really geared toward veterans. So I don't know if it would be of as much interest to the general population, because it's kind of veteran specific in some ways. And there are so many apps out there now. I mean, as you said, there's a slew of them. But I am still interested in finding out. I want to see if it's being accessed. Even by veterans or people that are using it for PTSD, that are stumbling upon it and finding it useful. So, thank you for the idea.
There you go. That's why we have these events. Well, I could keep picking your brain on app development. I have some interest in apps related to nurse staffing and scheduling and that kind of thing. But I realize we're only about 5 minutes before the top of the hour, when others may have things they, next appointments they need to make. Are there any last questions from the audience here before we dismiss everyone? Okay, without objection, that I'd like to thank you once again, Dr. DiNardo. Thank you so much for being here today. Really, we had a great turnout. I think that's a reflection of the topic and just interest in the intervention here. So we appreciate your time. And yeah, thank you so much. Thanks everyone for joining, and be on the lookout for another invitation for our next event.
Bye.
Bye. Thank you.